we've spoken a lot about the perceptions of health and disease in the context of global health. And I think a topic that has been historically underrepresented is what we're going to be dealing with right now. And so it gives me great pleasure to introduce our mental health panel and have mental health step into the limelight. We have some excellent speakers today. Dr. Melanie Abbas, Dr. Mary De Silva, Professor Michael Phillips, and Dr. Farnaz Sabet. And we are very also privileged to have it moderated by one of our own current scholars, Kirsten, who's a medical doctor from South Africa, currently reading for a DPhil in psychiatry. Take it away, Kirsten.
Thanks, Romina. Okay, thank you everyone for having the stamina to make it to the last session. We appreciate you making it this far. Of course, they saved the best for last, and I'm sure you're going to enjoy it. Yeah, as you know, mental health hasn't always sort of been on the global health agenda, but we're hoping for it to take more and more of a sort of central stage there and to not be forgotten about. Of course, it makes up a large part of the global burden of disease, especially in terms of years lived with disability, and it's probably undercounted as well. So it's something that we do need to be talking about. It has huge costs in terms of human capital and loss of GDP, but of course it's also a human rights issue, the fact that there's this huge mental health treatment gap between those who have mental illness and those who actually manage to access treatment. And in many countries, it's less than 1% of the budget is going onto mental health. So we're going to just start with the panelists introducing themselves and kind of their background and how they've been involved with mental health, and then we'll be kind of discussing how this fits into the global health agenda. So if Melanie, if you wouldn't mind starting.
Thanks, Kirsten. Okay, well, very simply, I think my career can be divided into two phases. One is I spent years and years working out how to measure depression and some other mental disorders in low-income countries. And the second phase is now much more focused on culturally adapting interventions. But I think running through that has been quite a lot of cross-cutting, so I'll very quickly say what I think those have been. So, and although they have slowed me down, I think I'm just about to peak. And I think that they have, although they've slowed me down, I think they've been very enriching. So one is that I've had a particular focus, at least for the last 10 years, on one country, which is Zimbabwe, and I think that allows you to really understand a lot about sustainability, about culture. And that comes within that is a lot of embedded capacity building, so that I have a team of kind of young, early and mid-career researchers there that I mentor, and that takes a lot of time, but incredibly rewarding. I think another thing is I've remained clinically active, and that really, I think, does keep my hand in terms of thinking about evidence-based treatments. And I think the third thing that I wasn't really anticipating, but about 5 or 6 years ago, I had my first episode of depression. And then 2 of my kids in ending school and early university also had sort of mixed anxiety and depression. And then sort of various stories started coming out of the woodwork about a grandmother who actually didn't die of cholera, but actually killed herself. And sadly, a nephew died recently from suicide. So I think I'm sort of increasingly seeing that although that has got in the way a bit, that it's really enriched and perhaps reinforced my commitment to treatments, particularly for young people, sort of finishing school, entering university, with depression and anxiety.
Thanks. Mary?
Thank you. So I've spent most of my academic career doing global mental health research, and I'm now, the last 2 years, I moved to be head of population health at the Wellcome Trust. So I've had a complete removal out of academia into the funding of science instead, which has been very rewarding and fruitful. Very briefly, my background in global mental health went along the translational pathway. So I started thinking about the social determinants of mental disorders. I got frustrated by not being able to change social determinants, so I moved into more intervention research and psychological therapy evaluation. I got frustrated with trials not being scaled up, so I moved into more implementation research, and I got frustrated with there being no funding for mental health, so I moved into advocacy and policy work, and then I realized that's death to an academic career, so I moved into funding. So that's me in a nutshell.
I'm a Canadian psychiatrist, a kind of public health psychiatrist who lived in China and worked in China for over 30 years in different parts of the country. So I've been a participant in the rapid rise of China that Lincoln was talking about yesterday, and seeing how both mental health and the research agendas in China have changed as they've moved from being funded by foreign sources to funding themselves, and that's been quite a dramatic change. I also do a lot of training in public health for fellows, both within China and long-distance training. My own research has been focused on suicide. I set up a suicide center, large epidemiological studies in serious mental illness, schizophrenia, and more recently I've worked on mental health policy and improving health services in poor areas of China.
Well, thank you for having me on this panel. It's a pleasure to be here. So my interest in mental health started from my first tutorial in psychiatry as a medical student, where I just was in awe of the human mind and what it can do and the extremes of pathology it can have that I was never aware of. But with time and with considering doing psychiatric training, in many of the countries that I traveled to and spoke with people, I unfortunately found that psychiatrists are also stigmatized as a profession. And so many people that need care don't even go to the psychiatrist. So that was one of the reasons I chose to train in family medicine as a frontline care worker. So firstly, to diagnose the undiagnosed mental illness, and secondly, the many psychosomatic presentations of mental illness that you see that present in different ways. From that time, I've sort of worked with many vulnerable populations, so Indigenous Australians, asylum seekers, refugees, and post-disaster in the Philippines. And now most recently, I've been teaching in Jordan, which has been a fascinating insight into how culture affects mental health and presentation, and how that my students, I'm academic clinicians, my students will listen to what I teach, but they don't believe what I'm teaching them. And so they will shut the book and say, but that's not how we do it here. And so I'm learning from them. I've been greatly privileged to learn from my patients and my students about how to actually apply some of the science into real-life mental health interventions.
Thank you. We know it's a big problem, but it's something where it's stigmatized. As you say, the profession can be stigmatized, the illness can be stigmatized. How do we make sure that globally, in terms of policy, in terms of funding, and at national levels, in some of these different contexts that you've all found yourselves in, how do we make sure that it's prioritized, that it's something that, where there are policies put into place, but they're not only that, but that the funding is put in place to back it up, and that translates to service delivery? Michael, perhaps in the Chinese context, what does this look like?
The WHO played an important role. In 1999, Brundtland came to China and had a presentation on moving mental health in developing countries. And the Minister of Health, at that time, the public health sector had not respected, figured mental health was sort of the last of the totem pole, the last person on the line to be fed. But when Brundtland gave a speech about mental health, the importance globally, then the Minister of Health had to respond. And that time, the global burden of disease had just come out. And so there was an ongoing debate that I was involved in, and finally they decided that they would accept the global burden of disease perception of mental health as a public health problem. And that completely transformed the perception of mental health, because then the public health ministry took it on as a core target for themselves. And it's also the first time that they ever publicly mentioned suicide, which was previously a taboo topic. So because suicide was a big issue in the global burden of disease. So that was a real stimulus to move us up the agenda and make us a public health problem, which made it so it resulted in resources, it resulted in a whole range of positive policy efforts on the part of the Chinese. Now, turning policy into reality is another issue, but it really got us on the chalkboard, which previously we weren't.
How about Zimbabwe?
Yeah, I had a couple of observations there. One is, I think things changed in Zimbabwe in terms of some of the attitudes when we started getting money for mental health research. So we have a lot to thank Mary and her colleagues and NIH for putting in the first big grant. Actually, that was President Obama's big fund. I remember sitting around a panel where people were discussing failures, postgraduate failures in the medical school, and really senior figures saying, okay, that ophthalmic surgeon has failed his exams 5 times, maybe, and he's got a mental illness, maybe he can do psychiatry, you know, as a career option, not as a treatment. So, no, this is serious. I'm being quite honest here. So, and you know, all the humor that came, the classic thing is, oh, why do you do psychiatry? You'll end up looking mad like your patients. That's what people say. So, when we got the first big grant, so that has really changed things in the medical school. The dean is very open. But I think also, I remember one colleague from Ethiopia saying to me, one of the big barriers is that people don't believe it's treatable. So I think I've been fortunate to be connected with a study called the Friendship Bench, a project called the Friendship Bench, where we've showed that using actually very simple treatments, you can actually improve people's symptoms in terms of depression and improve their day-to-day function. So producing local evidence. And my other tack has been integrating with other key platforms. So I spend a lot of my time working with HIV and depression. But I also think education and depression, workplace and depression are the ones that we need to look forward to for the next decade.
And in terms of the language around mental health, I mean, sometimes in some cultures there are just no words for depression, and it just, you know, how do you start the conversation when the language doesn't exist? How do you think culture sort of has an effect in contexts where, you know, the language doesn't even exist to talk about mental health?
My experience in developing scales to assess depression in China is that in rural China they don't use the word depression, but they have other words where they experience depression. You just have to find the right words, and you have to revise the instruments and use your different, so it's pain in the heart, and there's a couple of other expressions that were accepted as equivalents, and have done studies to show, in fact, those people meet Western criteria for depression. So that's one way you can work on it.
I mean, So culture's been fascinating for me because I'm working in a Middle Eastern culture that has strong religious beliefs and strong understandings of what the soul is, what the human body is, what the mind is, and even a belief that if you suffer, God values that suffering. You know, so therefore, even if I suffer in mental illness, it's a noble thing to suffer. So when I teach my students, I just see this incongruency between how Western mental health is currently taught and what they value. So Western mental health values the individual, it values autonomy, it values control, and that's not what my patients value. And so that's why I'm saying that they have a schism. They know they have to study what I'm teaching to pass their exams, but they don't practice it. And they don't see it in their patients, and they don't actually believe it. So there's many factors that affect it. One is the stigma. One is also the family resources. So health is not something that is between me and the patient in that setting. It's between me and the family. And a lot of the ways that we're taught doesn't acknowledge that. A big difference that I mentioned is the religious aspect. So by and far, people that have mental illness, including my medical students, will see traditional healer. So if my own medical students and my residents are not seeking medical care for mental illness, but are going to traditional healers, then what's the population seeking? And of course, those traditional healers are completely disconnected from the medical treatment. So I'm not saying, I mean, in one aspect there are gaps, but I'm actually saying that there is a strength in that culture that's being missed by us. So there is a dynamic, there is a community network, there is an understanding of suffering that's different that I don't understand and I don't have in my teaching. So what has happened is there's an import of mental health from elsewhere that doesn't have reflection. It's just passively imported. This is what I get taught in the States, therefore this is how I do mental health here. And that passive importation has lots of problems. So in this weekend, we've talked about using local people, but local isn't enough. It has to be local with a knowledge that's generated locally, not a local person simply importing knowledge from elsewhere. So there's much to say on this. I think Michael's wanting to say something.
Yeah, the individualist culture, individualist versus collective culture, has a lot of conflicts when you're trying to do research. Because in the West, they expect the individual to consent to everything, whereas in China and many Asian cultures, it's the family who makes the decision about healthcare. When a person gets admitted to the hospital, it's the family. And so the expectation that the individual makes all the decisions is a Western expectation, whereas in China, that simply isn't true. And in many Asian, Korea and other Asian countries, that's also an issue. And so when we get funded from the West, say, why don't you do it this way? But in fact, it's anathema to the way families deal with mental illness, because they are the responsible people who make the decisions. And so often when I work with IRBs, there's this conflict. Who signs the documents and who's making the decision about hospitalization or any other kind of service? And that's a problem in getting Western funded research because of the IRB expectation that the individual makes all the decisions.
I'm just thinking now in terms of this more local knowledge generation, understanding of mental illness as not merely kind of an individual thing and from a sort of very Western constructed way of thinking about it. How do we encourage more of that sort of local knowledge generation, more thinking about us as social beings, about the cultural context? It's quite difficult when people are importing tools, whether it be in terms of diagnosis and research, treatments from other parts of the world. How do we kind of encourage more local generation of knowledge, a kind of a local understanding of psychiatry and mental illness, including incorporating traditional healers and kind of local spiritual and cultural understandings of mental illness?
I mean, I can go on about this, and I don't want to. We can all go on about this.
The Delta scheme is a great way. I think if you build capacity in local researchers, that's one way to do it, because the fact is it takes time. You can't just jump in and jump out and just spend a few weeks here and there in a country, as a lot of global health researchers do, because, maybe not their fault, but because of their own cultural system where they work, they're only allowed short times to be away and they've got other commitments, teaching and so on. But the more we can do with really long-term partnerships and be supported through funding to do that, then I think we can, opportunities come up. I'm now working with a musician who is able to engage young people through the creative arts, and then we can do a bit of mental health type of counselling, but they wouldn't just come if you said it was counselling.
And remember, in all countries, there's huge diversity within the countries, especially the urban-rural divide. The inequities of services available in rural China compared to urban China are dramatic. And where I work now, 40% of the people have never been to school. I have 300 cases I've done of schizophrenia, and 3 of them have ever used a computer in their life. And so, and then I go in Shanghai, everybody has their own iPhone. And so you really got to think about inequity within countries, within minority groups, and they're different cultures. In a sense, they're different cultures. And you need to have complex methods of developing situation analysis before I implement a program that's done in the urban area in rural areas. You've got to do a situation analysis. How feasible is this in the setting? Why and why not? And there needs to be a science about the implementation, even within countries, within different subgroups within the country. And those are skills that aren't currently being taught. How you do multi-dimensional, cross-disciplinary situation analysis in a setting you want to implement any intervention.
But I think there is hope for, I don't think we can end up in a situation where you say every intervention has to be locally developed, originated, evaluated, and you end up with 17,000 different interventions. I think there's quite a lot of evidence now that there's transdiagnostic approaches which don't take a disorder-specific approach, but say there are core components to disorders in different settings, and there are core components to psychological therapies, which if you understand what that core is, and then how you then adapt that core to be suitable for use in other countries or other settings. I think that's the approach that we really should be targeting.
What I'm saying is we don't have the science for doing that adapting well. I agree there's core things, but the process of adapting it, you got to start with a good situation analysis on site. And then what is the science of adapting these things? And that hasn't been developed or funded sufficiently. And that's what people need to know to actually, you get the core amount and then to have to implement in a setting. What do you got to do? What is the process? And that has not been given sufficient emphasis.
So, and also just from my practical experience, there are very few researchers that really understand, like they grew up in the culture and understand it, and then also take this adaptation. So, because they leave. We haven't talked about brain drain this weekend, but whoever is going to be trained very well, especially in psychiatry, which is also in deficit in high-income countries, tend to leave. So what I've focused on, and there's no evidence behind it, but is my female students. Because my female medical students generally will not leave, but my male ones will. So when I'm working in mental health, there's a bit of bias there. Yes, it is. There's some gender bias.
I think you can probably justify a bit of bias.
I'm one of four here.
500 years.
But you've really got to think of very creative ways to how do you empower the thinking that we can generate something locally and it's valuable, and then two, how's that going to be sustained there? So, this is just in my own practice that I found that the people that do stay in the country have been my female medical students. So that's one way I've tried to build up local capacity and confidence in at least clinical care.
All my graduate students are females, by the way. And it's just, that's the reality in China. Because males want to be economists and be financiers, don't want to be doctors or researchers.
We're sort of starting to get into the retention literature now, because the program I mentioned that was funded first was through President Obama's Medical Education Partnership Initiative, and his vision was to build the capacity of 13 medical schools within Africa and form a network. And all the teaching was to be done in country, the absolute minimum of people moving out. And I think that's what the current Delta scheme is that Mary's organization is supporting, which is that all our students do PhDs in their own countries, and the first supervisor is within country at the local university. So it's going to be a slow process. I hope we'll get follow-on funding, because I don't think it's going to be sorted in I don't think it's going to be sorted in 5 years, because that's a long-haul commitment to build supervisory systems in a country where actually, I don't want to name names, but, let's say a country I know fairly well, a lot of the supervision is still done in this way that we accepted it being done 30 years ago in the UK, which is you see your supervisor on day one, and then you see them again 3 years later as you hand them your thesis. And supervision has got a lot better, hopefully, as some of the fellows here will be experiencing. So there's a lot that needs to happen to support universities who want to improve their systems.
And it's supervision and mentorship of researchers. It's just, it's what I see as one of the greatest weaknesses of current research structure in China is the mentorship process is just not effective. And it really undermines the quality and the value of research that's being done. The mentorship, because you get good mentors and they want to go to the West and work. And how do you get good mentors doing what needs to encourage researchers and get them to research topics that not are only going to get them published in a big journal, but are actually going to improve health or improve mental health in their communities. And that's a really uphill struggle that I've seen get worse in China, not get better.
How do you think the state could incentivize people to stay there and contribute?
The incentives, the problem is rural areas. You can't incentivize anybody to go and work in mental health.
There's no rural health allowance or kind of extra income that you get if you work in a rural area?
Well, it's been very problematic, and I think that's true in many developing countries. How do you incentivize people to go and stay in rural areas to provide any health services, not only mental health services? It's a chronic and unresolved problem.
So, Mary, I was just thinking in terms of funding, working at the Wellcome Trust, when it comes to mental health funding, how do you kind of decide how much should go towards supporting preventative interventions or, kind of research into prevention of mental illness, and how much should go towards treatment of existing mental illness?
So, I mean, the short answer is that Wellcome doesn't decide. Great people apply to us and we pick the best science on the day. But we do have strategic priority areas where we're trying to make a big change in a particular area. And we currently have one in drug-resistant infections and vaccines. And we're considering whether youth mental health, with a focus on prevention and early intervention, is going to be our new priority area. So we've got about another 9 months to go in the process of deciding that. And in the beginning of our scoping, we had the whole debate, is this going to be treatment of established disease or is it going to be prevention, promotion, early intervention? And quite early on, we decided that we would go for young people and we'd get in early when they're young. And the reason for that is because 3/4 of disorders start before the age of 24. And once they've started and become very established, they become extremely hard to treat. And we do have some good interventions, but they are no way good enough. So, and the number of people who are suffering from some form of mental distress is far too large for any health system to ever be able to manage. So we want to try a different tact. And it's not to say that treatment isn't critically important, and we still fund 300+ million in terms of neuroscience and mental health research anyway, which is largely focused towards treatment. But the lack of research funding into prevention and early detection is so big that we felt that Wellcome could have a role in really bolstering prevention and promotion research in young people, because it is the most orphan of all of the mental health orphaned research fields.
What do you think, Melanie? I know you do a lot of intervention research.
And I think it's very exciting. I was actually just looking at, there's a meta-analysis that was published just last week or the week before on prevention of anxiety, actually, and they concluded that both, I think, psychological interventions and educational interventions could have a significant but very small effect in terms of anxiety prevention. And this was across the lifespan, whereas a lot of studies have focused on children before, whereas they looked at, right across. I do think we probably take for granted in this country the degree of mental health literacy we have. The fact is, it's become much more acceptable now to talk about stress, to have, what was it somebody tweeted a few weeks ago about, or a few months ago on, I'm having a mental health day at home, and it went a bit viral because it was saying it's great that someone's boss would allow you to have a day off. Now, that is, it's something that we are working much better towards. Mindfulness at work now is available for a lot of young people. So I think we take for granted how little knowledge people, as Michael said, in rural settings, people who don't have access to, to regular internet, that they just don't have that kind of knowledge. So I would have thought you could potentially have some quite big gains in terms of mental health literacy. What I don't know is with early intervention, it's almost like a catch-22 because a lot of the mental disorders currently rely on them having impairing function or having lasted for 6 months, say the case of anxiety, before you would even diagnose it. So we'll have to look at diagnostic systems if we're going to start, so that will be quite a revolutionary change.
I think the problem with prevention studies in developing countries is they take a long time. Ideally, you have panel studies. You're following people for 20 years and see if those interventions prevent subsequent suicide, subsequent violence, subsequent alcoholism. And you need to have those long panel studies. The developing countries have the populations could do that, but the research structure doesn't support that because graduates need to get their papers out soon. It isn't high, typically it's not going to get you a Lancet paper, it's not high status. So it's very hard to establish and continue a long-term program because the prevention, you are follow them a long time. Does it work or not? What other outcomes you're kind of looking at? And that type of research is extremely hard to motivate people to do in developing countries, and given the current research culture that exists in developing countries. But I agree, it's extremely important, but how do you get researchers who need a paper in the next 6 months to be willing to commit their energies to doing that?
So that's exactly why Wellcome would be able to invest, and we're talking between £100 and £300 million that we'd be investing.
I'll take 100. Thank you.
Fine,
I'll take 100. Would you like 100? So there you are.
Yeah, we can split it up. You guys
I go home. But the idea is that these priority areas don't follow normal funding structures, that we can do, we can fund very large research investments, we can fund commission pieces of work, we can do basically whatever we like. And Wellcome has a very long history of funding large-scale longitudinal population studies. For example, Steve Tolman and the Agincourt DSS site in South Africa. There are many examples of studies which Wellcome have funded which have lasted 20, 30 years. And we can build on those existing research infrastructure platforms to embed mental health measurements in them. So we don't necessarily have to start a whole new panel survey from scratch. We can use existing structures.
But if you're working in developing countries.
Yeah, these structures are in developing countries.
Okay.
Yeah, I mean, there's the Kuduri, the China Kuduri Biobank, 500,000 people across representative geography of China. We've funded that for years now. We could easily add mental health measures into the Kuduri Biobank.
I mean, this is just a practical experience. When I was working in Northern Australia with the Indigenous population, and I shared this a little bit with the panel, there was such a high rate of mental illness that if you were just looking at treatment, by the time you treated the parents, the children were already suffering, you know, because they had missed out on that critical parenting that they needed. And so I was speaking to a child and adolescent psychiatrist, an amazing man, who said when he started 20 years ago, it was just him. He was servicing everyone from the top of Australia. And now he's resourced with 100 staff, and he says it's not any better. So it's not that having that extra access made things better, because the core problem was starting before they got to the treatment. So I think there are definitely circumstances where the disadvantage is so entrenched that you have to look at prevention, otherwise you're just chasing your tail. Yeah.
And I think what's really needed is a reconceptualization of what we mean by mental health and mental illness, and having a really strong dichotomy between that person's sick and this person is well. That just adds to our PR issue, where you have to wait till you've had anxiety for 6 months before you'll be given any treatment, and then you have to wait a year for treatment. Or in the UK, it's 10 years for a young person between onset of symptoms and effective treatment. It's 10 years in the UK. So imagine what it's like in most other countries of the world. So to break that dichotomy and instead think of mental health as a continuum where wellness and illness happen in fluctuation, happen over the life course. There's variations between how severe people are, and then where you intervene on that pathway is can be very personality specific, if you see what I mean. So we need to start thinking much earlier on how we create literacy and wellness in more people, and then so the people that really do need care get it. Because at the moment, the danger is this over-medicalisation of distress means that our health systems are being overburdened by people who might not even need that kind of intervention. And we're not leaving space for the smaller proportion of people that actually do need serious clinical care. So we need to redefine what we mean by mental health.
I mean, but then this sort of takes mental health into the sphere of other sectors, of course. I mean, education, for example. What do you think the role is of the education system, of our schools, primary schools, secondary schools? I mean, because you think prevention doesn't happen at a hospital, it doesn't happen once you've reached a health facility, it's happening earlier on upstream. So how do we kind of incorporate prevention then into school curricula, for example?
So I would go broader than schools, and this is the same with all health, that I think we need to be thinking of systems, not individuals. So partly because of biomedicine and clinical science, we're all trained to think about individuals and what can you do to that person to make them better. And what we never do is step back and look at the system that's making that person sick. And that might be an education system which makes people sit tests every 5 minutes and academic achievement is the only important thing, instead of having an education system which grows children to be comfortable in their own skin. We have, cities which aren't built for mental wellness. So I think we need to step right back and think of the individual in the context in which they live and start trying to change the system rather than putting all the onus on the individual.
So I want to share it's a bit off topic, but I worked on suicide prevention in Afghani women. It was a fascinating place because the system, one of the root causes was gender inequity. And then what was happening is that NGOs were going to promote gender rights for women, and women couldn't get those rights So they're now being told a picture that they can have, but they can't have it. And so the only expression for some of them was to self-immolate, to commit suicide. And it was starting a movement in this. So the complexity with some of mental, and I'm just putting this back, is that some of the underlying systemic issues are so big and so deep and so unjust that leads to the suffering of people that you find that many funders will just fund the clinical care model. Because, of course, I can give you an antidepressant, but to address the underlying issue is a whole other ballgame. So this is one of the complex areas in mental health I find, even with asylum seekers, with refugees, that it's much easier to open a clinic than to address the issue.
And the variability. Now, I was involved in the WHO first report on suicide, and the variability in age-adjusted rates around the world is 100-fold by nation, 100-fold variable rate of suicide. Just think of that, what that means. And some of that is sort of soft data, and if you look at the hardest data we got, it's at least 50-fold difference in the rate of suicide. And in China, suicide is only peripherally related to mental illness. Mental illness does not drive the suicide rates. In fact, the suicide rates in China have dropped 50% in the last 20 years. 50%. China is one of the 3 or 4 countries that are going to achieve the Sustainable Development Goal, reducing suicide rates by 1/3 by 2030. Like almost 95% of countries aren't going to get to that goal. But and within China, and in India, the rates across India in 26 provinces, 26 states, is 20-fold in the rates of suicide. So you've got to, you can't think of a nation even, because there's subgroups within nations, and particularly suicide, its relation to mental illness is certainly there, but it varies across the country. And like in China, 10 years ago, there were more women than men who died of suicide, whereas almost all Western countries, 3 times as many men as women. So the role of society and culture on determining suicide rates is quite dramatic.
What do you think caused that shift in China in
Well,
terms of suicide?
I would like to say it's all our suicide prevention services, but in fact, the real reason, or what I presume to be the real reason, is one, the rapid improvement in economic status, so people feel that their children are going to be better off than them, and 2, rapid urbanization. Over the last 25 years, China's gone from 20% urban to 55% urban. 300 million people have become urbanized. And what does that mean in terms of suicide? It means they don't have daily access to agricultural pesticide, which is the most common method of suicide in China. So the urbanization result in a drop, and the improvement in economic conditions result in a very dramatic 50% drop in the rate. Over 20 years, there's 100,000 less suicides a year in China than there was 20 years ago. And if you think there's only 800,000 in the world a year, that's a huge impact on global suicide rates.
I'm just going to probably say something controversial now, but if you had poor eyesight, okay, you could ask your family to sort yourself as a rail. You could, stop driving. You could do all sorts of things to optimize, but you would also be willing to wear a pair of glasses, which would help your vision. And I think we're in danger by talking about prevention. And actually, even though a lot of my work is on psychological therapies, I think we're in danger of forgetting that we do have some very effective drugs for mental illnesses. And actually, I think that the big swing to talking therapies is actually denying people access to drug treatment. We like to say in the Friendship Bench, we're terribly, only 8% of people ended up having an antidepressant. Well, actually, does that mean that the people in our trial, were the staff weren't trained enough to offer antidepressants to people? Or does it mean that we were actually treating distress and not clinical depression? So otherwise, it doesn't quite make sense. So I think we have to be a bit careful. And it's not just in Zimbabwe or China or India. I sit in my clinic in London and I see people referred from wonderful counselling services who've been treated as victims of torture for 6 years with therapy. And they come and I can see they've got a barn door case of severe depression. and you put them on an antidepressant, and within a month, I have a lady at the moment, an African lady, she's off to Canada to see her son in Montreal. This was a person who could almost hardly stand. So I think we are forgetting a bit of our training, and we have to stand up and make sure. So I was actually going to ask Naledi after the tea today, do you offer exposure therapy to women who've been raped and who have post-traumatic stress 6 months or a year after? Probably not, because a lot of the work on PTSD has been done by NGOs in refugee situations outside government services. We haven't mainstreamed simple evidence-based treatments yet. And my career, I'm not going to have 30, 40 years to wait for the prevention, but I do have things I'd like to pass on and see people benefit from them. So keep funding a bit of treatment.
What do you think the role is of primary healthcare and family medicine? I think, in many countries like Zimbabwe, there's so few psychiatrists. For the burden of disease, we kind of need a task-shifting approach. We need to get community health workers involved. We need to get the GPs involved, the nursing staff. So how do you think we approach this task-shifting? Do you think that's important?
I think the next thing is going to be training traditional healers to prescribe SSRIs, actually. Yeah, it's not easy. You can teach somebody in a couple of days, probably, but we're not doing it. That would be a nice study.
Yeah, I think actually Mary yesterday suggested a report that I should read, and I read it. And she said this happened in Jordan. I was like, well, I never saw it happen, and I still didn't see it happen. But the biggest barrier was the psychiatrists to actually doing this task shifting and to putting it into the care of the primary care physicians, because it was talked about last night, but there's a lot of power in this field. Even when I talk about the way education is done from a mental health perspective, there's power involved there. And there's power in the medical profession. Why isn't a nurse doing it, let alone a family doctor doing it? A lay person can do much of the counseling that's needed you're saying that the medical system is clogged up. And it's definitely clogged up. So once I've got a presentation, often it comes psychosomatic, but thereafter I don't need to keep reviewing the patient. They can go elsewhere. And we actually have the people in power in the medical industry sort of don't allow that to happen, because especially in many of the developing world countries, or at least where I work, it's a private system. So you actually want to see the clogging up. You actually want to clog up the private system, unfortunately, and you want to keep seeing cases that could be managed by a less trained individual. So I definitely think it's the way to go, but we need a bit of a release of power from traditional places that have held it.
Well, China isn't a private system. It's practically all government run. And there, the problem is that the village doctors have so many other responsibilities that they just can't take on mental health, and we try, and the government is very eager to communitize services and wants those services provided at all the community levels. But in most, other than the rural areas right close to big urban areas where they can use urban resources, those that are somewhat peripheral to urban areas, there simply isn't the manpower. And there's no nurses, there's no social workers, no other potential health aides who could help in. And we're not talking about depression. We're just talking monitoring people with severe mental illnesses who are taking antipsychotics and making sure they got them. So what happens is we have the Disabled Persons Federation, which is a social welfare agency, just handing out antipsychotics. And there's no monitoring. Just every 3 months you come in and we give you a bottle of pills free. The China has the money to hand it out, but the monitoring is limited or non-existent. And so because the village doctors simply have to take care of all these other priorities. And again, it's incentivizing people to work in the rural areas is a uphill struggle. And they've tried lots of models and none of them have really worked.
I think that speaks to the fundamental problem with mental health, is that certainly as part of the global mental health movement, it took us a long time to be bold enough to stand up and say we need more money. There is not enough money in this world for mental health services or for research. The UK spends more in a week on cups of coffee than the world spends in a year on development assistance for mental health. There is simply not enough money in the system. So we've struggled, we've gone around the edges saying, let's do task shifting because that's cheaper. Let's do short, brief psychological therapies because that's cheaper. And actually, in reality, they've turned out to be really effective. But we've only discovered that because we've been trying to do things without any extra resources. And that has to stop. We need more money.
Yeah, but my point is that China has the money, but they still can't do it. China has a lot of money. They pump into research, they pump into services, and they still can't do it. The infrastructure's in there. You can't get people willing to work. You pay them no much. How much are you pay them? They won't go there. They don't have a place for the kids to go to school. Just can't get them to work in those rural areas. And so money isn't always sufficient. I think it should be. Well, the Chinese experience suggests it might not be.
Have they considered task shifting?
But they don't have anybody else they can task shift to. They've got the village doctor, nobody else. And there's one possibility that I'm trying to work on. They have the women's cadres who were previously responsible for ensuring the one-child per family policy, which China now has sort of relaxed because they have this huge burden of elderly, and so they're trying to get a little more young people who can support them. In any case, there's these women's cadres in most centers, and we might be able to task shift there. So that's a potential target. But other than that, there's nobody around that we could even potentially use.
So I'm aware of time and that we did start the panel late. So I'd like to just quickly ask one point from each of you of something you'd like to see change in the next, say, 5 years in terms of global mental health. And then we'll open it up to some questions from the floor. So maybe starting at that end, if you have any thoughts.
I think much greater use of evidence-based treatments for anxiety and depression.
I want to see a reconceptualization of mental health as a multidisciplinary, multi-system thing.
I think there needs to be recognition that the people with severe mental illnesses have a 15-year shorter life expectancy than other people. This is a travesty. This is a human rights travesty that's global. It's high income, low income, it goes everywhere. But nowhere is that fact, if there was any group that had 15 years less of a shorter life expectancy than any other group, there'd be outrage. But where's the outrage about this for seriously mentally ill people who have 15 years less of life? I want some attention paid on that. I think that's the lever we got to clobber people with at government levels and other levels to get some real action in this area.
It's going to be hard to follow. No, really, I think a lot of people suffer so silently. I mean, in every setting, developing world or otherwise, and that's really what I'd like to see change. That people don't suffer the anxiety or the depression or the mental distress on their own, and that there's a support network that's good for them, that doesn't just give Valium out, but actually is good. And one thing that I think we didn't talk about, but really would help me in my current setting, is breaking the stigma around it. And I've often just thought, look, forget about research, forget about medicine. It needs to be in movies. It needs to be in the public arena. It needs someone famous coming out and saying something. And I think that would change the perception of it much greater than however much as a doctor I can talk about it. So I really would like, and ultimately that is so that the people don't suffer by themselves anymore, that they get their suffering addressed.
Thanks. So we'd like to take questions from the floor now, if we have any. I think Shirelle has the roving mic. So perhaps we can, how many questions are there by show of hands? Are there quite a few? Okay, and that's fine. We'll take, I think, 3, and then we can open it up to the panel.
Thank you for a most passionate, I was on the edge of my seat. It's quite a passionate address. Thank you all for sharing your experiences. I was struck a lot by Farnaz's comments on kind of contextualizing how both you approach and treat in the Middle East. And I'm just wondering also a bit about your points about capacity building. Thinking how UNHCR is now working in Zaatari and other refugee camps on bringing some kind of early mental health and psychological assessment programs. Do you think, 1, these have been thought through and they are contextualized, and 2, there's an opportunity in kind of capturing that moment, both for research, but also maybe some of the stigma issues that you discussed?
I mean, there's a doc. Oh, sorry.
It might be easier because it was sort of a 2-tiered question, maybe to just answer it. That's fine.
I'll be quite quick, Liliane. Thank you. They have done a document on how to address mental health. I mean, there's been research in Syrian refugees specifically. I mean, this is something we didn't touch, but actually you'll find that in that setting, the two largest funded areas are NCDs and mental health. And sometimes I have questions about that, whether you're trying to fund the suffering that comes from a larger injustice by providing a mental health service. So
rather than dealing with the injustice.
Rather than dealing with the injustice. So it's heavily funded. I mean, you have a war going on, you have trauma from the war, what can you do about it? Let's provide counseling services. So it's needed. I'm not saying it's not needed, but I have queries about the political background to why it's so well funded in that setting. And I do think UNHCR is doing excellent work though, and they're trying to contextualize it, but this type of real deep thinking is very anthropological and needs a long time. And a humanitarian emergency just doesn't give that time, I think, to really think deeply about how that culture sees mental health and how to treat it. So I would understand that they're applying best evidence practices as we know it and trying to adapt it in that situation, not develop something new.
Okay, two more. There were some other hands here at the back. Charles?
Thank you very much to the speakers for such an excellent presentation. I'm probably temporarily one of the people that were mentioned in the brain drain. I trained in Kenya, but currently doing my residency in psychiatry in the US. My question to the panelists would be that I know we focused a lot on the negative side, the unmet need, the burden, but if you look at the practice of where you're working now, are there any positive things that maybe people would emulate or look at that show that over the past few years we've made some progress, particularly in low and middle income countries?
So before I left academia, I co-founded something called the Mental Health Innovation Network. Just Google Mental Health Innovation Network. And what we did was document evidence-based examples of great mental health practice all around the world, with a particular focus on low and middle income countries. And then we set up this community of practice around those things, so that when you wanted to create a new depression program in Kenya, for example, you could look and say, oh, and someone in Tanzania has done something similar, there's the training manuals, this is the evidence base, let's adapt rather than reinvent the wheel. And so I'd really urge you to look at the Mental Health Innovation Network website. It's got nearly 4,000 members globally now, and nearly 200 innovations listed on it. So I got bored of people saying, well, what's good practice, basically, so we decided to document it.
Okay. Any more questions? I think there was one more. Yes, Anisha?
Hi. First of all, I didn't know that you made that, and I've used it in my research, so thanks so much. But question about, a lot of you mentioned just the sort of sheer shortage of psychiatrists and psychologists everywhere, and like in a lot of other healthcare fields, technology has been talked about a lot in terms of being able to leapfrog that gap a little bit. But always there's a lot of hype about especially mobile health technologies without necessarily delivering the outcomes that it's promised to do. So I was just wondering if any of you have worked with any technologies that you think help address the gap in access, and if so, what have you found effective? If not, what do you think that technology can and can't do for mental health?
We have just started, so the very simple therapy that we use in Zimbabwe on the friendship bench is just called problem-solving therapy, and it's very easy to learn and effective. It's got an evidence base. So Phillips Electronics have developed an app of that. They've worked with people in Kenya as well, so it's great to have the comment from Kenya, and that's called Inuka. And I think they've launched it as an app. And the business model is, I think there's a low level of advice that you can get that's free. And then if you actually want to have some one-to-one interaction with a counsellor, then there's a paid service. And I think they're potentially interested. I don't know if you know, Phillips have an Africa hub, an African Innovation Hub, and they're kind of, you probably know all this, but I didn't know. So they're very busy. I'm very interested in getting into mental health possibilities. But I must say, there are so many self-help ideas out there which are being trialed in this country. But when you look at a self-help manual, for instance, just look at one alone, like coping, overcoming fear, that's a whole book, you know, and the notion of it would be a real labor of love, I think, for someone to take on a really good self-help and translate that and make it usable. But there are a really lot of apps like, what's it called, Mood Juice, Mood Gym, not Mood Juice, that we could, I think, could be used and are being used by more advantaged, say, young people in low-income countries who hear about them, but they're just available in English.
Well, we've translated some of Mood Gym into Chinese, and the research looks pretty good. On the other hand, the use of cell phones to remind people to take their pills and things like that, a number of studies in China don't, so it doesn't look like it really works. I've seen several. So there's different, you know, and of course it's different age groups, and urban-rural utilization will be quite different.
I think certainly the use of digital technologies is something we're really interested in investigating for Wellcome's priority area. I think there's huge potential not just for delivering treatments at scale cheaply, but also detecting mental disorders quicker and improving health systems to deliver better interventions. And I think we've got apps now where you can monitor moods and symptoms on smartphones to detect whether somebody might be spiraling down. So I think there's huge potential, there's huge ethical issues. The lack of regulation is a massive issue. The proliferation of technology without evaluation is a huge issue. So I think the entire field needs to get a grip quite quickly if the promise is going to be achieved.
I just wanted to add, I think, you know, in the Middle East, everyone uses social media. I mean, the Arab Spring, I mean, politically, it was driven through social media. So it's a huge platform, but on the flip side, it also leads to isolation, which is, again, one of the things that is linked to mental illness. So it's how, as we were talking about, how you use the family network and the collective network, but still use a platform that's quite individual-based, and that I think is a challenge that needs to be addressed and is a potential.
I think also go speak to Josh about MindStrong. I think he'll have more to say around the use of mobile technology in mental health. But yeah, thank you very much to our wonderful panel. We've really enjoyed listening to you all, hearing your opinions and experiences, and thanks to you as an audience for your questions and for listening so attentively at the end of a Sunday and after a long conference. Yeah, thanks.